My name is Magda Geruferiani and I'm one of the internal medicine specialists. Very recently we have reached £13,000 in donations, and this is a huge achievement for all of us. I would like to thank all of you for participating and donating, all the presenters for their time, passion and dedication into delivering cutting-edge lectures, Sting and Yaitha for helping significantly reach this goal, Paolo for organizing the lectures and making them a memorable event each time, and Daniela for being the strong woman she is, for putting everything together from the scratch. I could not be happier and more honored to be part of this project. But most of all, I would like to thank all our colleagues that they have stayed behind in Ukraine, and one way or another they are trying to help all lives there, and they are trying to make a difference. I hope God is seeing them and protecting them. Most of all, I would like to hope that leaders around the world will understand the value of life, human and non, and how much more important this is compared to territory and finances. Thank you very much for your time, and I hope you will enjoy the lecture tonight. Bye-bye.
Because I know it's Sunday night, and we
just need to reiterate the quote from Bob Geldof years ago, which was, "Give us the bloody money."
Yeah, okay, maybe. Okay, give us the bloody money. Good evening, everyone, and welcome back. I'm Daniela Murgia from Vets4Ukraine2022. And I would like, first thing, I would like to thanks Magda Geruferiani for her nice video message that she just sent to us. Magda was very brave, was the first of us that did her webinar on the first live episode of Vets4Ukraine2022. Magda, if you remember, spoke about immunomediated hemolytic anemia, and she did her webinar in a moment where, so we were just born and we didn't have much experience. We went live on YouTube, on LinkedIn and on Facebook. We were not live on YouTube, for example. And everything was very new. We were not very experienced, and things have changed much since then, from the layout of our presentation. And since then, we have also many other specialists. We were 15 at the beginning, and now we are more than 30, and more others are coming and joining us. We have done this to raise funds for the Ukrainian people and to help the British Red Cross to support people affected by the war in Ukraine. So today is a special live because we have two special points to discuss. One, I will keep it as a surprise. The second surprise is are the guests that we have tonight. You have seen in the previous slide that Paolo has showed you that our guest is Benoît Cuq, is an internal medicine specialist, is working at the UCD Dublin, is a specialist in internal medicine, as I mentioned, and he will talk about urinary incontinence. But before starting with Benoît, I'd like to invite here a person who many of you very likely know, because he's very famous. He's a very famous neurologist, and he has been the inspiration of Vets4Ukraine2022 project. Basically, to cut a long story short, Vets4Ukraine2022 was born following the example that these colleagues, neurology colleagues, organized. So they organize a series of webinars on neurology topics. I'm talking about Laurent Garouzi, which I would invite here in our live, because I would like to thank him in person for the help, for the support, and for all the suggestions that he has given me and Paolo to set up these live episodes. Paolo, have we got Laurent?
Good evening.
Hello, Laurent. How are you? Thank you for being with us today. It's a real pleasure, even because this is the very first time that we see each other, we speak to each other looking in our eyes. So the very first contact was 2 months ago, when I sent a text or messenger to Laurent and say, look, Laurent, I would like to do something similar to what Vet Oracle has done. Can you help me? How did you organize that? And he gave me all the necessary information, and he suggested also the live platform with StreamYard, and for this, Paul and I and all the Vets for Ukraine community are very grateful to Laurent. So, Laurent, you are not in the UK.
No.
You are overseas. So
absolutely. But if I remember, if I'm correct, we actually spoke on a Sunday morning. I think you called me over the weekend, and that's what I love about all the campaign that have been running, and run by the vet. It was the spontaneity of this campaign, and it was not a matter of thinking twice. Are we going to do that? It was, we're going to do it. And you had exactly the same attitude. It was not like, oh, I'm not sure, I want to do it, tell me how we do it. And that's the way it started. And what was impressive is, I give you a few tips, but you literally took it to another level of what we did. And before we went on live, I mentioned to you, the design is absolutely amazing and it's very eye-catchy. And clearly with Paolo, you form an amazing team to have put all this together. And the last thing I would say is, there've been a lot of changes in the profession over the last few years, and we all know that there is more and more corporate ownership. But the fact of the matter is, it hasn't changed the fundamental DNA of the vet, and we are a caring profession. We care about our animal, we care about their owner, but we care about our colleague. And what you did and what we did previously just show what is our DNA, which is we are a caring profession.
We are caring for, in our profession, for our patients, but also for the human beings, because we need to be caring. So we see here the slide. So you reached a very high amount of money, and would you be happy to mention all the people, all the colleagues that have helped you in this?
And we talk about spontaneity, but I tend to have this random idea, usually when I go swimming or I take the dog out, and I have this idea coming up more out of frustration that I need to do something, for Ukraine. And I contacted my old mate, Simon. We were always together, doing any project, Simon Platt. And he said, yeah, let's do it. And within 2 hours, I was emailing, the brilliant neurologists you see, Elsa Beltran, Olga Volk, Niklas Bergnot, Chris Falzon. And, there was not one ounce of hesitation from them. Again, the spontaneity was there. And I'm sure, I've seen you had so many people that came, to do talk for you. And, I was impressed how quickly they reply. And it was a yes. There was no question about how it's going to happen. It was, yes, I'm in. And that's fantastic. That's absolutely amazing.
You're right, because I remember when I after having spoken to you, and I sent an email to, even before having organized anything, I just sent an email to 15 specialists. Actually, obviously, my main contacts were surgeons, okay, soft tissue surgeons. So I started to send the email to them, including some of my friend medics or oncologists, and I was really not very optimistic. I would say probably they are so busy that they will never they will never accept this type of commitment. And so within 24 hours, all 15 people I contacted, they were on board. We have created a WhatsApp group, and then from this beginning, then other specialists will say, "Oh, this is amazing what you're doing. I also would like to participate, to offer a webinar." So to the point that we were said, "Okay, now we need to organize these 15 people. Let organize all this, and then we will come back to you." And for example, Benoît is one of these person, because he immediately asked, "Oh, I would like to be on board. I would like to help." I said, "Yes, okay, Benoît, let me deal with the first 15, and then once we will probably will extend the calendar, and then you will be on board." Therefore, I think, so what I feel is the amazing bit of everything is that we came together, all together, we did that, and to help someone else beyond the competition, beyond what is we live every day, maybe between specialists and different disciplines. Amazing. So and this brings me to ask you, because from our original group, we left out the neurologists, because we thought, okay, Vet Oracle has done this with neurologists and we don't want to overlap with them. But to be honest, we would be very honored if you wanted, if you had time.
Paolo warned me already.
Oh, okay. So we haven't spoken.
We haven't.
So we would very honored to have you on board, but you don't have to say yes now.
Of course, I will. Of course,
it would be great to have you on board.
Paolo knows you too well.
Fantastic. Okay, thank you very much. Thank you, Laurent,
for your. And again, well done to all of
you. Thank you. I would like to. So this is the 21st episode. I have another exceptional colleague that we are now inviting in our life, and he has had also a very important role, because he's a showman. To be honest, he's very good in talking, and he is also the person that has brought us to have a lot of donations. So Paolo, shall we invite Stein, please?
Goodbye, everyone.
And here we are. So we have Yaifa and Stein from Amsterdam. Hello, Hugo. How are you?
We're fine. Thanks very much. Hello, Laurent.
Hi, guys.
Bonsoir. Thanks for introducing
me. Like Eurovision with all the
languages. Yes.
Thanks for introducing me as the clown of the specialist. I really appreciate that.
I'm not the clown of the specialist. I said showman, which is not an insult. It's actually a compliment.
I think he likes that. He enjoys being the clown. So that was a huge compliment for him. Yeah.
Thank you very much. And beautiful words from Laurent, and very recognizable, right? It's all about the awful situation in Ukraine, unimaginable that we are talking about war within Europe, and incredibly frustrating. So the frustrations that Laurent was talking about, I mean, I think loads of us in the profession have felt that, is we are no soldiers. We can't go there and fight for them. We can only do what we are best at, and that is use our skills in the way we can do that best, but still try to get some sort of result for those who need it most, and those are the folks in Ukraine. And that's what has drawn a lot of us to it. Jaitha, you're going to join the Vets4Ukraine series of lectures shortly as well, I believe.
I mean, at Q, we need to find a date, but I'm sure we will.
I haven't forgotten you, Jason. Yeah, we will fix the date for you as well.
You're becoming too popular, This is the problem. This is there's now there's now a big queue, but that's only good.
No, you are not in the queue because there is a date for you. I haven't just told you, and we need to double check. So don't worry, you're not in the queue. So,
Well, the other thing I wanted to say is, and Laurent was rightly saying, it's not a competition, right? So there are a few initiatives. There was also a great day organized by the Webinar Vet, like a marathon. They raised an incredible amount of money. So it's not a competition, but a bit of healthy competition is, of course, very good for the Ukrainian cause. So, Laurent, can you just remind us how much money you guys raised with the great neurology lectures?
Yeah, just over £13,000.
13,000, yeah. Fantastic. Congratulations on that effort. I mean, we can only dream of ever achieving that, of course. Sorry, the doorbell is going. Just a minute. I know this is live, but Jaitha, can you just get that? Might be a middleman, I think. So sorry about that. I know everyone is waiting for Benoît to do a beautiful talk, but I think it's an important package. Maybe what's that?
It was a letter.
A letter.
Yeah, for Vets4Ukraine.
That's Vets4Ukraine.
Oh my God, what is that?
Yeah. Wow. It's incredible that they knew our address. It's becoming such a famous thing. We better open it. Wow. That's a large thing. Very large thing.
Look at that.
So, it's a very large thing that is coming out of here. I don't know if you can see it here, but it seems to be a check.
So what
it seems to be a very large.
Our colleagues of Vets4Ukraine2022, and whoa! Oh God!
I was counting the zero.
We are showing off $10,000. Fantastic.
So it's not a competition, but it's a healthy competition of colleagues all trying to do their best and trying to raise awareness above everything, but also a bit of money to help those in need. And we're honored tonight to present on behalf of the Veterinary Information Network, specifically the European Department of the Veterinary Information Network, this little donation to support what Daniela, Paolo, and all the veterinary specialists have been doing, and to augment the efforts also by Laurent and the neurologist, also the Webinar Vet. I mean, the more we can do together as a profession, the better.
Because with this $10,000, we are we are at 13,000 as well. No? So if we put our 13,000 together with the 13,000 of Laurence, we are 26,000. So Laurence and the neurology colleagues have donated to the UNICEF, and we are doing to the British Red Blue Cross. But I think it's crazy what we have done. I think it's crazy, unbelievable. I would have not bet that we would have managed to do that. So, and you have been the inspiration, Laurent, and you should be really proud of that. Yeah.
Thank you.
Very good.
Oh. Shall we?
Yeah, maybe I just wanted to mention as well, because the founder of the Veterinary Information Network, Dr. Paul Payan, was really generous in providing this. When he heard that a bunch of European colleagues were taking action, he said, well, let me know how I can support this. And he's a very honorable man. He sent a message as well. He said, I don't want to be in the limelight. He's not a type that wants to be in the limelight, but I did want to read out a message from him, which he put with the donation. So this is Dr. Paul Payan, founder of the Veterinary Information Network. So he says, let's have a look. I've got it here. The cruel invasion, destruction, and murder of citizens of Ukraine has placed an unfathomable burden on our colleagues in Ukraine and all their country mates. Let us know how else we can help. That's all he said. And then $10,000 came through, a real symbol of the man. And it is this little token, which he calls a little token. We think it's a quite significant token that hopefully helps keep the momentum in the Vets4Ukraine campaign.
And that's to remind to all of you on the other side of the camera, please, first of all, share the link so that we can reach as many people as possible and make our cultural movement bigger and bigger. And then don't forget to, if you have the financial possibility, to click on the link www.justgiving.com/Vets4Ukraine. Click the link and donate what you can, even a little bit. A little, every little helps, every little counts, and keep on helping us, helping our brothers and sisters in Ukraine, because they still need us. Okay, so I think. Do you want to introduce Benoît now? So because he's waiting for us to start his talk, he's nervous too, and he's really looking forward to start.
No worries. Back to business, right? Back to the series. And today we've got the excellent opportunity to listen to one of our fantastic colleagues in internal medicine, Benoît. And he is a specialist in internal medicine. He trained as a veterinary surgeon in France, but then did further education in Canada, in a variety of places, internships in, I believe, Ontario. Benoît might have to correct me on that. Above all, he is one of those people that spontaneously wanted to do something. He is currently working at the University of Dublin as associate professor, I believe, in internal medicine, doing all kinds of funky stuff, also in terms of interventions. So it's going to be a fantastic talk. He is French. He therefore loves his food. He loves his wine. He loves his two cats, but isn't afraid to leave them alone because he loves traveling as well. So maybe after this talk, we can get some sort of hints on what kind of best wine we should be using to celebrate the 10,000 extra donation that we received today, and B, figure out what our summer destination should be, where we can celebrate after hopefully a very successful Vets4Ukraine campaign. So without further ado, if Paolo is ready in the engine room of Vets4Ukraine, then we should get Benoît popping up very shortly. Benoît, how are you there?
I am there, yeah.
Hello, Benoît. Welcome. Thank you for joining us. How do you feel? Are you nervous?
No, I'm all right. I'm all right. Don't worry at
You're
all.
all right. Okay.
And thank you for
So
organizing
before,
that.
yeah, sorry, before giving you the word, I would like to maybe ask Laurent before he goes, if you can stay, Laurent, I'm not sending you away, but maybe would it be would it be possible to ask you, feel free to say no, to give a message in French to our French colleagues to support Ukraine and maybe to donate wherever they can donate. So
that's the most embarrassing thing. I can do any silly thing in English. I can make a fool of myself, but I get very shy speaking in French.
Okay.
It's the same for you, Benoît. It's absolutely.
It's the same.
I'm sure Benoît can do a better job because.
Okay. I can't French, so I can't do it. So we leave it. I can do it in Italian.
So, Benoît, I think you do a better job.
I started in Italian, but then I will ask Yaisa to do it in Spanish if she is okay, and I will ask Stein to do it in Dutch. Yeah, deal? Ok. So, cari amici in Italia, se ci state seguendo, questo è Vets4Ukraine2022 questo messaggio è per voi. Come vedete stiamo mettendo insieme tanti webinar per voi, fatti da specialisti, per voi in general practice o nella vita ambulatoriale di tutti i giorni, e se vi piacciono i nostri webinar, donate quel che potete, pochi euro vanno bene perché ogni piccola donazione è importante, soprattutto pensate ai nostri amici, colleghi, fratelli e sorelle in Ucraina che hanno bisogno del nostro aiuto, quindi aiutateci. Abbiamo raggiunto recentemente le 13.000 sterline per la Croce Rossa e vi prego, aiutateci a portare questa somma magari ai 15.000. Donate. Grazie mille. Yaisa.
Bueno, hola a todos desde Holanda, pero con un mensaje en español para, pues recordaros a todos que, nos hemos juntado unos cuantos especialistas, o muchos especialistas, y hemos puesto, pues una iniciativa en acción para ayudar a nuestros compañeros en Ucrania, no solo compañeros veterinarios, sino personas, compañeros humanos, para intentar ayudarles de alguna manera que podemos en esta guerra tan horrible que están soportando. Y pues esta ha sido nuestra manera, el dar seminarios online gratuitos a cambio de una donación, no importa lo pequeña que sea, por supuesto si es grande pues mejor, pero no importa lo pequeña que sea, son seminarios impartidos por especialistas de temas relevantes para cualquier veterinario en clínicas veterinarias de primera opinión. Y esperamos que os unáis a nosotros en este movimiento y que donéis lo más que podáis, que compartáis pues este link y esta iniciativa con todos los veterinarios que podáis para que así podamos seguir ayudando a nuestros compañeros humanos de Ucrania. Un saludo.
Goedenavond, welkom hier bij Vets4Ukraine. Vanavond krijgen we weer een fantastische lezing van een van de top internal medicine personen van de wereld. Deze lezingen worden georganiseerd met één doel in gedachten, om te zorgen dat we onze ogen niet afwijken van de verschrikkingen die gebeuren in Oekraïne. Dus laat dit vooral wederom een herinnering zijn dat we moeten blijven waken over onze broers en zusters in Oekraïne. En als jullie ook nog eens zouden kunnen doneren, een klein beetje geld kan al heel veel helpen in het opvangen van mensen die door de oorlog in Oekraïne zijn getroffen. Dan alsjeblieft ga naar justgiving.com/Vets4Ukraine. Geniet van deze lecture. Het gaat weer een fantastische zijn. Dank jullie wel.
Fantastic. French, no? In French?
Oui, bonsoir à tous les vétérinaires français qui sont parmi nous. Bien sûr, c'est un webinaire supplémentaire dans la série des webinaires de Vets4Ukraine. Comme d'habitude, c'est un webinaire qui sera gratuit, destiné à tous les praticiens généralistes. Et comme tous les webinaires précédents, vous pouvez les retrouver sur la chaîne YouTube que Daniela a organisée. Et il y a le lien, bien sûr, pour Just Giving pour pouvoir faire vos donations pour la British Red Cross et leur action spéciale pour l'Ukraine. Bonne soirée.
Fantastic. Thank you so much. Thank you, everyone. So I was thinking, shall I do it in German? But I'm not that good, so I can't do it in German unless Stein or any one of you speaks German.
Ich könnte das machen, aber ich werde nur ein Ding sagen. Gib uns das Geld. Give me the money.
Genau, gib uns das Geld. nicht scheu sein. Donieren, liebe Freunde in Deutschland. So, entschuldige für unsere Deutsch. Also wir sind in England, so wir können kein Deutsch mehr. So ich konnte einmal. So many thanks, and I think Laurent, thank you so much. We let you go. It was so, as I said, I'm very grateful. We are all very grateful for your help, and we are looking forward to having you here with one of your fantastic neurologist webinars. Thanks you.
Paolo.
Laurent, bye.
Thank you.
Bye-bye.
Bye.
So, Yaisa and Stein, are you also going?
We'll stick around and enjoy the fantastic seminar, of course.
Fantastic. Thank you for being here, Yaisa. We give you a feedback for the date for your presentation. Okay, and now it's time to let Benoît finally talk and tell us about urinary incontinence. Thank you, Yaisa. Thank you, Stein. See you later.
Bye.
Bye.
Bye. Excellent. Back to English then to discuss about urinary incontinence. As I mentioned, this is a topic that is quite common in general practice, and I think most of you, regardless of where you are practicing, you've been facing patients that presented to you for urinary incontinence. It's important to recognize that disorders of urination have been more frequently recognized recently in small animal practice, and that's probably due to the fact that the way pets are housed has changed, and obviously pets being housed more and more inside the house increases the reports by the owners that they might have inappropriate urination. And these will create situations that are very distressing for both the pet and the owners. And it's very important to be able to investigate them, understand them, and as much as we can, treat them. If we start with some definition for urinary incontinence, it represents the loss of the voluntary control of urination. And that will lead to inappropriate emission of urine, which is often qualified by the owners of leakage. And it will have, again, a very big impact on the lifestyle of both the patient and the owners. It's important when we are discussing urinary incontinence to recognize that there are two main factors that are at play there. One is structural abnormality of the urinary tract itself, or more of a functional imbalance between the storage capacity of the bladder and the urethral tone, which will lead to this leakage. When we look at the anatomy of the bladder, it can be divided into three specific parts: the apex, the body, and the neck, which I've tried to illustrate on my beautiful drawing, as you can see on the slide here. The ureters, which are linking the kidneys to the bladder, are entering at the level of the base of what we call the trigone, and they will insert an open there to deliver the urine, which will be stored in the bladder. The urethra is going from the apex to the outside and will be closed and helping the bladder to fill and to store the urine. The smooth muscle that compose the bladder are arranged in different bundles with very variable orientation. And that is quite important because that detrusor muscle, as we call it, will have a very intricate functioning. And therefore, as soon as the contraction of that muscle will start, these very intricate fibers will all respond together and lead to very homogeneous and continuous contraction of the bladder, leading ultimately to the emptying of the bladder. This smooth muscle will extend to the proximal part of the urethra, and they will compose what we usually call the internal urethral sphincter. And starting towards mid-urethra, they will be joined and then replaced by the urethralis muscle, which is a striated muscle, and will compose what we call the external urethral sphincter. And it's the mechanism, the intricate mechanism of both these muscle groups that will lead to continence, allowing for the urethra to have a tone all along, which is even more emphasized by the folds of the urethral mucosa that are going to co-opt together and even strengthen the closure of the urethra itself. Now, if we look at the pathophysiology of urination, the control of micturition is obtained through a combination of voluntary and involuntary component. So there is always that awkward moment where we have to learn and try to remember the innervation of the bladder. The involuntary or sympathetic innervation is supplied by the hypogastric nerve, and that will be the main regulator for the filling phase of the bladder. There will be a stimulation that will then result in contraction of smooth muscle that are forming the internal urethral sphincter, so that will close that urethral sphincter. And there will, in the same time, be a stimulation of the beta-adrenergic fibers, which will induce a relaxation of the detrusor muscle. And you can obviously understand that closing the urethra and relaxing the bladder will lead to a filling and storage phase. Then there will be the emptying of the bladder, which is mostly controlled by stretch receptors, which will mark the maximum distension that the bladder can achieve and induce both somatic and parasympathetic response, leading to the exact opposite mechanism with a relaxation of the urethra and an opening of the urethra and the contraction of that detrusor muscle, leading to an emptying of the bladder. So that will be your emptying phase, and it's going to be a combination between a conscious voiding signal, which will be necessary to activate the contraction of the detrusor, and then an arc reflex that will lead to the relaxation of the urethra. If we look at the differentials for incontinence, it's important to base your differentials on your suspicion of your patient having either a small bladder and incontinence or a very distant bladder and incontinence. If you have a normal or a small bladder on abdominal palpation at the time of the physical examination, the suspicion is that you're going to have a filling disorder. The bladder is unable to hold a normal volume of urine and therefore will be normal to small on abdominal palpation. This is mostly associated with anatomic abnormalities, decreased bladder compliance, or decreased urethral tone. If we go a little bit further in differentials, we will have for anatomic abnormalities, ectopic ureters, which were one of the most common cause of urinary incontinence due to anatomic abnormalities, pelvic bladders, fistula with communication between the urinary tract and something else, either the rectum, the vagina, and therefore the urine is escaping somewhere else, persistent urachus or vestibular strictures that are reported as well. If we go with decreased bladder compliance, the urge incontinence due to usually inflammation, neoplasia, or urolithiasis is what is the most commonly reported, as well as the idiopathic detrusor instability, which leads to an abnormal contraction of the bladder that is quite involuntary. Finally, the decreased urethral tone will be secondary to what we call the urethral sphincter mechanism incompetence, or USMI. This is also probably with ectopic ureter the second most common cause for urinary incontinence to which you will be confronted in your practice. As I've described before, the urethra is all along a combination of smooth and then striated muscles, and therefore the previous thought that there were two sphincters at each end is gone, and we know that it's really a combination of effects of both of these muscle groups plus the coaptation of the urethral mucosa that form this urethral sphincter mechanism. And if it's not working, that's when you diagnose your patient with urethral sphincter mechanism incompetence. Now, if on your physical examination you have a distended bladder, then the feeling phase is appropriate and is able to happen. However, there is something that prevents a normal emptying of the bladder. That can be due to an anatomical urethral obstruction, an obstruction of the urethra, and you will have what you call overflow incontinence, meaning that the urine will be emitted sporadically, uncontrollably, when it managed to finally get around the obstruction. That obstruction can be a stone, could be a mass. You could have a functional urethral obstruction, which are associated mostly in large breed dog males with vesicourethral or detrusor-urethral dyssynergia, which is a neurological imbalance and desynchronization between the bladder and the detrusor contraction and the urethra and the urethral mechanism to lift its closure and allow the free passage of urine at the same time as the detrusor contracts. And finally, you could have neurological abnormalities as well that are associated with this. And that could be associated with what we call a lower motor neuron, an upper motor neuron, or detrusor atony. If we want to go a little bit further in the neurological abnormalities, we can bring back the scheme of the bladder innervation. A lower motor neuron will be a disorder that is affecting the sacral spinal cord or the pelvic nerves, and that will interrupt the local arc reflex at the level of that spinal cord and will lead to the detrusor and sphincter hyporeflexia. Therefore, you get a very distended bladder because the stretch receptors are not able to communicate their message anymore. But that bladder can be easily expressed because the arc reflex that contracts the urethra is no longer present. So you have this big distended bladder that you can easily express. Now, if we move forward to the upper motor neuron disorder, we have a disorder that will occur in the space cranial to the sacral spinal cord. So anywhere higher than that. And usually it's associated with disc herniation or fibrocartilaginous embolism. There is no longer any somatic perception of the distension of the bladder, and the detrusor atony, although initially intact, will be damaged by the chronic overdistension, leading to a difficulty for the bladder to contract and empty itself normally. So you will have, in these cases, a bladder that is very distended, but very difficult to express. So based on your history and based on your physical examination, urinary incontinence is one of these diseases where your clinical feeling will already help you to refine your differential list and classify by likelihood, congenital or acquired disorders? Do you suspect something neurological or not? That will be based obviously on the patient and its characteristic. Age, breed, reproductive status are always very important to communicate with the owners when you are dealing with an incontinence case. You also want to obtain from the owners a very thorough description of the leakage. When does it occur? How often? How important? Can the patient void normally in between? And I think nowadays we are lucky enough that most people have a camera in their phone and should be eventually able to record some of these episodes. And that will also help you to classify and to rank your differentials for urinary incontinence. And finally, what is also very important is to confront the history and the descriptions that the owners are giving you with other diseases that could either be concomitant or mimic incontinence, and that maybe the owners are not able to describe properly. So it's important to assess if there is polyuria versus incontinence, and that will all be based on the consciousness at the time of the leakage. Is the dog consciously voiding, but multiple times at different places, polyuria, pollakiuria, or is the dog voiding without any conscious of it, which will be then an incontinence? Does the dog has nocturia? Does it happen mostly at night? Does it happen anytime during the day? These are all very important questions to ask. PUPD has to be also questioned with the owners, because sometimes it's just the dog can't get to the door because he's so PUPD that's going to void in the house. Any history of neurological disease, back pain. It's important to ask about the defecation as well, to make sure that there is no other signs associated with disease, maybe involving more of the anatomical region that are all associated together. And so it's very, very important to have a thorough discussion with your owners about all of these cases. Finally, you want to perform a physical examination. The physical examination should be obviously complete and associated with a neurological examination for incontinence. You have a physical examination that should start from the nose and goes to the tail, as usual, with your auscultation. It's important to look at the skin, look at the vulva, because you might see signs of consequences from the urinary incontinence. So if you have a male, it's important to exteriorize the penis to see if there is any mass, any trauma, if you can palpate eventually along the penile urethra a stone, a mass, anything. It's important to look at the groin and inner thigh skin, because you can see dermatitis associated with the urine staining and the constant urine soaking that is present in this area, like you can see on the picture from that dog. You want to perform a rectal exam as well, because that will help you to assess the urethra. You can palpate the urethra underneath the rectum and assess for masses, stones. You want to palpate the prostate if you are dealing with a male. And if you flip your fingers 180 degrees, you can palpate the sublumbar area and see if you have any lymph node enlargements as well. As I said, you want to finish your physical examination by performing a neurological examination and try to find if there is any evidence of concomitant neurological disorders, and that might help you localize or classify the incontinence maybe in a bigger disease group. So we are going to talk about 3 patients tonight overall. The first one is Alfie. Alfie is a young male dog that is presented for incontinence with his skin being slightly irritated by urine soaking all the time. His bed is wet every morning when he wakes up, and he's dribbling some urine in the house intermittently. We also have Tess. Tess is a 6-month-old cross-breed dog who was dribbling urine since birth. Everywhere she goes in the house, you can follow her because there is a trail just behind her, and she is the dog that you saw in the physical exam slide with that vulvar reaction and dermatitis. And finally, Alpha, who was a very young Labrador that was referred to our dermatologist for a non-responsive dermatitis at the level of the inner thigh and groin. And when our dermatologist saw the dog and started to question the owners, the owner mentioned that she was not yet well-trained and she would urinate all the time. It appeared that the dog was actually leaking all the time, and that these dermatitis was suspected to be contact dermatitis associated with the urine that was present. And as you can see, it can take very dramatic extent. So some of these cases might be more severe than others when they present to you. In terms of diagnostic investigation, the minimal database is usually to make sure that they are overall healthy, otherwise than their incontinence, and that usually can start with some basic blood works. One of the very important tests to do is obviously your urinalysis, and that will also help you to distinguish PUPD from incontinence as well, based on your USG. We've mentioned in our differential list a bit earlier that infection and inflammation was associated with some particular type of incontinence. So obviously urine culture and sensitivity might be indicated in some of these cases, either because there are suggestions of inflammation and infection on your urinalysis, or because you're planning to do maybe a more invasive type of investigation like an endoscopy, and you want to make sure that you're not going to perform this in an infected bladder. If we were talking about older patients, so that's obviously not something we would consider for the 3 patients that we have presented just now. But if you were to suspect a neoplasia of the urinary tract, such as transitional cell carcinoma, you could also send some specific tests on the urine, like the BRAF mutation, to try to get a first answer about that cancer without doing anything invasive to your patient. Once you've collected these non-invasive data and refined eventually your differential, then will come the question of the diagnostic imaging. Diagnostic imaging for the urinary tract can encompass ultrasound, radiography, CT, contrast study, urodynamic studies, and they all will give you different pieces of information. Radiographs might be very good to look at urolithiasis. Ultrasound might be better to give you an insight of the overall anatomy of the urinary tract, the presence of a mass, the presence of any kind of anatomical abnormalities. CT will look at kind of everything, obviously, and can be paired with a contrast study. So an intravenous urocystogram through your CT, where you can highlight the entire urinary tract with contrast to look at the positioning of the ureter, for example, or a possible fistula. And finally, you can do urodynamic studies using fluoroscopy, where you can inject contrast as well and see where the contrast goes using fluoroscopy and retrograde study this time with a catheterized patient. But what is, I think, very important in incontinent dogs is to consider eventually that you will have to perform an endoscopy, a urethrocystoscopy, going retrograde into the urinary tract with a flexible or rigid scope, depending on the gender of your patient, to obtain images and look at the overall organization of the urinary tract. Of course, depending on the presentation and the patient, and we will see that in the rest of the presentation, you might not jump on that endoscopy right away, but it's something that should be mentioned, and the owners should be prepared that if the investigations or the medical trials don't go the way you expect them to go, the endoscopy should be considered. So we were dealing with 3 puppies, Alpha, Alfie, and Tess. They were all less than 1 year old. So obviously, all of you were thinking ectopic ureters, and you were all right. Ectopic ureters are an anatomical abnormality. They are a congenital disease in most of the cases. Therefore, puppies are really high in terms of signalment and how to narrow down your differential to like almost 1 to go to ectopic ureters. They are reported mostly in female compared to males, and they are associated with a persistent incontinence from birth or from adoption, with a dog that will be dribbling urine when they are walking, worse when they are laying down, leaving a puddle when they sit, or leaving a puddle when they nap, having their bed completely wet every morning. The patient is often soaked, smelly. Eventually, they can have these dermatitis that we've seen for the 3 of them to a variable degree. And on physical examination, you might be able to see the dog drip urine in the consult room. Alpha, the big Labrador, was dripping urine, although I never managed to get a nice video of it. You could see the urine just dripping from her as she was standing on the exam table, and we were all discussing and doing the physical examination. The urine scald, the dermatitis we've discussed already. And then when you palpate the bladder is normal size to small. And that is due to the underlying condition, which is an abnormal location of the ureters, which is the definition of ectopic. If you have a normal ureter, as we said at the very beginning, they usually enter and start to attach to the body of the bladder, and then they open in the trigone, so before reaching the urethra. When they are abnormal, they are going to open in a different location. One of the most common presentation is what we call an intraluminal ureteral ectopia, where the ureter comes from the kidney, will try to enter the bladder, but will just run through the bladder walls and open further distally into the urethra. So you can see that that tunnel will open further down. Therefore, the urine will be released not inside the bladder, but already in the urethra, ready to come out. You can have an extraluminal ureteral ectopia, and that is a ureter that lives its life in the abdomen, and instead of coming and nicely attaching to the trigone, will attach further down in the urethra, and in some cases report even attached directly to another organ, such as the vagina or the rectum. Intraluminal is much more common. Intraluminal is something that we can treat by minimally invasive interventions, and we will go back there, versus extraluminal that becomes a surgical disease and need to be addressed with a reimplantation, a neo-ureterocystotomy, a reimplantation of that ureter in the right location. All of these abnormalities can be unilateral or bilateral, and there is no real rule, and you could have a combination of an intraluminal and an extraluminal as well in the same patient. So now if you were to try to go further, female, we said, are more represented. Intramural are more common than extramural. It's important to realize that the retrospective studies that have looked at this anomaly have also identified a lot of other comorbidities. Renal dysplasia has been associated with ectopic ureters. Abnormal morphology of the ureters themselves, like a dilation with a hydroureter, sometimes associated with dilation of the kidney and hydronephrosis, have been reported. And this is because there is sometimes a stenosis at the end and the opening of the ureter. So it's opening in the wrong place, but it's also not opening fully, and the flow of urine is not good enough, and we distend the ureter and eventually the kidney. It's often associated with a small bladder, sometimes a pelvic bladder. It can be associated with a congenital USMI. So you could have a urethra that is on its own already not very well functioning. And it's also often associated with what we call a paramesonephric remnant, which is a band of tissue that closes the vagina of these dogs, well, the female ones at least. It's important to rule out your urinary tract infection as one of the causes for incontinence, but also to make sure that you can perform the interventions that you might need to perform in your patient. Because they are so young, sometimes if the clinical signs are a bit difficult or not continuous, behavioral and toilet training issues have to be discussed with the owners to be really, really certain that we are dealing with incontinence. And as we said before, the diagnostic approach consists of the minimal database that we can obtain like non-invasively with some bloods, urinalysis, a urine culture, And then comes the question of diagnostic imaging. So what is the best way to do investigation from an ectopic ureter? What do I want to know from the imagers? What are my questions to them? Well, what I want to know is, do I have any of the other comorbidities? How sure can they be that these ureters are ectopic? So for that, we can use an ultrasound, because it's going to give us a good assessment of the urinary tract. We should be able to follow the ureters. Are we able to see the opening? That's always the question. We could use more advanced imaging like CT or endoscopy. Ultrasound can be very useful, and I think if it's suggestive of an ectopic ureter, that's great. The difficulty is to have somebody who is skilled enough to see the ureters and to be able to follow them all along to eventually reach the opening. On the picture here, this is another ectopic ureter that we treated here, none of the three that I presented, but we could see that the ureter was going beyond the urinary bladder trigone, and that therefore it was suspicious for an ectopic ureter. And that has been recently published by a team from Cambridge, who has shown that actually ultrasound is a quite sensitive and specific tool to detect ectopic ureter in urinary incontinent dog. It's a small study in terms of number, but it was really good to see that using cystoscopy as the gold standard and comparing to the ultrasound results that they had, if they were overall trying to classify the dogs as ectopic or non-ectopic, they had a specificity of 100%. So if they had changes on the ultrasound suggestive of an ectopic ureter, they were all the time right. The numbers were a bit different depending on the side of the ectopia, but overall I think it was a very nice study to show that ultrasound, which is widely available and not extremely expensive, could be a very nice first step to investigate this patient and give you the confidence that maybe they have an ectopic ureter. The next type of study that is quite common at the moment is to perform a CT IVU, so a computed tomography with contrast that will highlight the urinary tract. You can see here that the kidneys are both very well visible, and we also can follow nicely the ureter in that patient. And if you pay attention to the arrows at the bottom of the image, you can see that the bladder is not uptaking any of the contrast. However, you can see that the three bottom arrows are delineating a little pipe that continues along the bladder down the urethra, and that is highly suspicious for an ectopic ureter. Another case where CT, I think, is for me very, very helpful are male dogs, because in male dogs we have often that stenosis of the ureter when they enter the urinary tract, and the distension of the ureter is here very well visible on the CT scan. And then the question with the dogs is always, the male dogs, where do they open? Because if they open in the prostate, sometimes they're a bit more difficult to find due to the prostatic canalicles when we do the endoscopy. And here you can see that the prostate is very well delineated on the CT, and that the flow of urine is very faint from the bladder to the urethra, and even more faint from that ureter to the urethra. But we can see both flows here on that CT, and it gives me at least, the knowledge beforehand of where I have to look for to find the opening of that ureter. And then the cystoscopy, which I have mentioned before. Endoscopy will allow for a direct identification of the urethral opening, normal or abnormal. And it's considered the gold standard for the diagnosis of urethral ectopia. I would add that for me, it's the gold standard, and if it's paired with a fluoroscopy, it strengthens your ability to qualify these ectopic ureters. Are they intramural or extramural? And the fluoroscopy will allow you to do intra-endoscopy contrast studies to kind of confirm what you see on the scope with the fluoroscopic images to assess the the entrance point of the ureter and know if it's intramural or extramural. With the endoscopy, you will also be able to see if you have a double opening of the same ureter. So in that case here, I hope you can all see my arrow, but you had an opening here, which was actually quite near the trigone, and that dog had a nice normal uptake of contrast into his bladder. But then here we had another opening, and that was the same ureter tunneling a little bit further than it should have. Or sometimes you enter the vestibule of a patient and you just wonder what you are facing because you can't identify any structure. But among this kind of amalgamous thing, you would have to kind of pause and look at it to identify here your urethral meatus. And you can already kind of guess here the membrane of an ectopic ureter. This will be a very big permesonephric remnant, and this will be both the openings of the vagina. So that is something you can't see. That degree of malformation you cannot assess with ultrasound or with CT. So that's why it's really, really important that even if you're strongly suspicious of an ectopic ureter on CT, let's say, you want to do your cystoscopy, to confirm it, but also to assess for other anatomical abnormalities that can't be captured by this advanced imaging. Now, how do we treat them? Well, historically, we have done surgeries where we have reimplanted the ureter into its normal position. The technique differs a little bit between intramural and extramural, but overall the same. And Daniela can interject at the end of the topic to discuss that. But basically reimplanting the ureter where it should have opened in the first place. And it shows a complete resolution of incontinence in about half of these cases. And then an improvement in most of the other cases, knowing that it might need some more medical management further. The delay of the neutering is suspected to improve the response to surgery. And that's something that we do think that letting these puppies have at least one cycle of hormonal impregnation might strengthen their urethral tone and help preventing further USMI in the future. And as you can see, 25% will still require medication for USMI. The rest will still be incontinent despite the surgery and the medical management on top of that. And this patient will probably have recommendation for a urethral occluder, which we will approach a little bit later. The other option for treatment would be a minimally invasive approach for the treatment. And that includes visualizing your ectopic ureter on endoscopy and catheterizing it to be able to isolate it and use a laser to come and cut the tissue that is in the way. And by doing this, you're going to move back up that opening inside the bladder where it should be. This is done with endoscopy and fluoroscopic control to make sure that you push back your ureter as high as you can and as close as you can from the trigone. Obviously, this is only possible if you have an intramural ectopic ureter. As I said before, extramural ectopic ureters have to be treated by surgery. So this is a very quick video of a diode in one of the patients we've done here. That was a male dog. And with the diode, it's very nice because it's very clean. There is not a lot of tissue damages. So we are going very cautiously along the catheter to make sure that it's secure and that we are not obviously perforating the urinary tract and leading to a uroabdomen. The outcome of that procedure, which is called cystoscopic guided laser ablation of ectopic ureters, is unknown. There are only 2 very recent studies that have been available and published within the past 6 months. Both of them are retrospective clinical studies based on 34 and 31 dogs, respectively. And they have been assessing a continence score before and after the procedure. In the top article, in the VetSurg article, I think they have been looking at it at 1 month and 1 year post-surgery. And in the bottom article, they have been looking at it before and 1 month after the procedure. And they both shown a significant increase in that continence score, so a marked improvement in the continence before and after the procedure. They showed that the complication or perioperative disturbances were very low. Some patients might have a mild hematuria, but usually self-resolving within 24-48 hours. And then they also showed that the neutering, and that was in the first paper, the neutering did not impact the overall result of the continence score in the long run, and that's why they did the 1 year survey. So that was nice to show that we could then spay these dogs later on, and that will not affect the continence score that they had achieved with the cystoscopic guided laser ablation. Basically, they've shown that 1 dog in the second paper and 3 dogs in the first paper failed to respond to the procedure plus medical management for USMI. And these dogs obviously will need to have further treatment for their incontinence afterwards. But that's still a very low number of dogs, 1 out of 31 and 3 out of 35. So it shows that this procedure, plus or minus some medical management, has a very good outcome for these patients with a very minimally invasive way to treat this anatomical abnormality. So if we go back to the 3 patients that we were following, Tess had the procedure performed and she was what we call dry after the procedure, so she didn't need any additional treatment. She developed a UTI at Corynebacterium following the procedure, which has resolved, and she has been living her best life since. Like I've seen her a year ago, and since then we've just emailed back and forth with the owners, and she's completely normal. Alpha also had the procedure. We actually repeated the procedure a second time because she remained exactly the same in terms of the severity of the incontinence. And we tried to laser them a little bit higher up because I felt like there was still a bit of room for improvement. It improved things a little bit, enough to resolve the skin lesions. However, she was still incontinent, and she had an occluder placed a few weeks ago, actually, because she failed medical management. And finally, Alfie had a cystoscopy that showed a normally located uretero-vesical junction, and therefore his incontinence, although he was a very young dog, was not secondary to ureterolectopia, but to something else. And as we've mentioned quite a lot, something else in most of these dogs will be a urethral sphincter mechanism incompetence, or USMI. And as we've discussed before, the continence depends on the bladder capacity of accommodating the urine and the urethral tone. The urethral tone being guided by the tone of smooth muscles and striated muscles, but also by surrounding things like the intra-abdominal pressure on the urinary tract as a whole, and also by the length and the width of the urethra itself, which will vary from one patient to the other. So again, we don't think that there is one sphincter that is leaky and has to be replaced. That would be too easy. But we think that it's a combination of factors involving both of these muscle groups, the coaptation, the intra-abdominal pressure, the muscle tone of some of these dogs, that will influence their ability to have a proper urethral tone. This type of incontinence is reported in 3 to 20% of female spayed dog, and it's been extensively studied and described in female spayed dog because it's something that is associated with hormone deprivation and very well described in the spayed female, and it usually appears a few years following the spay, although I feel like we've been recognizing that these patients often present younger or sooner than that nowadays. It's been shown that it's associated with the loss of estrogen, and that will decrease both the sympathetic tone and the smooth muscle contraction. It's also suspected that it has an overall effect in the muscle tone of these dogs, and the surroundings, as I said, might be important. And if the muscle tone overall of that area in the body is lower, they might not have enough pressure on the urinary tract to keep a normal tone in the urethra. So there are discussions to now recommend probably to spay the patient a little bit later, which creates debates between the prevention of mammary gland carcinomas versus letting them have a normal development and maybe one full cycle of hormonal impregnation. And that's probably something that will be looked at and studied in the next few years. In terms of breed, there are some breeds where there is a very high prevalence for that disease, such as Irish Setters, Doberman, Bearded Collie, Rough Collies, Dalmatian. And it's been described in male dogs like Alfie, but it's a more rare occurrence, obviously. So as we said, it's a disease of the adult female dogs, but congenital USMI does exist. And it's the same type of presentation as the ectopic ureters, except that either it develops later in life if it's associated with the spay. It also usually progresses from the owner perceiving something is not quite right to the owner describing like full-on incontinence, and that can progress over a month to years. On physical examination, the bladder of the patient is going to be of a normal size. Based on the age and the clinical presentation, you might rank USMI higher than ectopic ureters because it's a 5-year-old spayed Doberman. So obviously ectopic ureter seems to be a bit lower down the list. I would not completely rule it out in an adult, but obviously it goes at the bottom of the list. There is a decreased compliance of that bladder, and so these clinical signs will progress as the compliance worsens, and so you will make that assumption of USMI based on the history and the physical examination. And probably that's where I think the diagnostic approach can be tweaked a little bit. You will obtain your non-invasive data as we've discussed before, but then if you highly suspect a USMI, are you going to go through the extent of doing the imaging? Well, maybe not if you don't have access to it very easily, or if your patient has some money constraint and you might want to do a medical trial before. I would still rule out, obviously, ideally stones. So I would still recommend to perform at least abdominal radiographs or an abdominal ultrasound, and obviously to rule out an infection and perform a urine culture. But then considering to do a medical trial is not necessarily a bad idea if your suspicion is high enough for a USMI. However, if your patient fails medical treatment and medical trial, then you can go and do more advanced imaging and eventually a cystoscopy. What is important to know is that the gold standard would be to perform a urodynamic study to evaluate the relationship between the pressure and the flow of urine between the bladder and the urethra. However, this is very rarely available. To my knowledge, there is only one center in the UK that offers that service, and that's Highcroft in Bristol. There is one in Paris, and I am not too sure about mainland Europe where it might also be available. But very, very few of these patients get to have that gold standard, and therefore the diagnosis will be based on the clinical presentation and ruling out everything else. The treatment options, you know them because I'm sure you've been already exposed to these cases, but phenylpropanolamine, PPA, is the mainstream one. It's an adrenergic agonist, so it's going to help strengthen the contraction of these urethral muscles. The smooth muscle will be strongly contracted, or hopefully more strongly contracted, and it can include some hypertension and use some restlessness, tachycardia in some dogs, and some dogs will not tolerate it very well. It has a very good response rate, and it's associated with a resolution of incontinence in 85% of this population of adult spayed female. It also has been used in male, and its response rate is a bit more variable, with only 44% of male that present resolution of the clinical signs. Estriol or other estrogen replacement therapy have also been used. And they have a different mechanism of action, probably strengthening more of the striated muscle strength and improving the responsiveness of the sympathetic nervous system. They have very few side effects because the dose we use is really, really, really low, although on paper, they could induce some clinical signs associated with estrus. Therefore, your swollen vulva, eventually vulvovaginitis associated with it. And some dogs have had reported gastrointestinal upset. In the worst case scenario, if you were to overdose the dog a lot, you could create a bone marrow suppression, but usually the dose that we are reaching for in urinary incontinence are so low that this has not been reported. And then if you've tried one or the other, I would recommend to try both together, because it's been shown that there is a synergistic effect between both drugs that will enhance the response to both, and therefore likely increase your response rate to the medication. Other treatment for urethral disease could consist of bulking agent, making this urethra tighter and narrower, using collagen injections. The main issue with them are that it's a temporary fix. And it's a temporary fix for which it's very difficult to predict how long it's going to last. And you can see that between the publication, the effects were lasting between 5 months and 16.5 months. It's not a cheap treatment. And so it's difficult to be like, oh yeah, let's spend all of that money, but it's only going to fix your dog for 6 months and then we have to do it again. It could be used as a transient treatment while the owner are making decisions about next steps. There is a new product that has been out on the market for maybe, I don't know, 1 or 2 years that seemed to have a longer effect of about a year, but I don't have more experience except the publications that are available about that product. And finally, the artificial urethral occluder, which I've mentioned a few times already. To me, this represents a very good option for the refractory cases where I suspect a urethral dysfunction, either like adult USMI, post-pay USMI, or these puppies with ectopic ureters where I suspect their urinary tract is not quite normal and they don't, despite the procedure to correct the ectopic ureter, despite medication, have a good response and they remain incontinent enough that it's a bother for the owners or for themselves. These occluders are made of a cuff, which can be inflated with sterile water, and they are placed around the proximal urethra, and eventually, not the day of the placement, but eventually inflated with sterile saline until we reach a balance between a good coaptation of your urethral mucosa, a good narrowing of the urethra, but the ability for the patient to still void normally. So it takes a few trial and errors to adjust the volume until we reach that steady state where there is a good control of the incontinence, but the patient is still able to void consciously and normally with a normal emptying of the bladder. It's been studied pre-commercial release and after the commercial release, and it's been nicely shown that if you look at the continence score, there is a significant improvement in that continence score pre-occluder and post-occluder even at 6 weeks. Complications associated with it included dysuria from probably pain or maybe strictures, as well as infection with bacterial cystitis. In dog, USMI does exist, and the investigation will be the same. For Alfie, we pushed the investigation up to an endoscopy because he was so young and we suspected an ectopic ureter. We then tried PPA with Alfie, which did not work. And then we tried testosterone, which also did not work. So Alfie had an occluder that was placed, and that did not include it, but there is a very recent publication in JSAP about occluders in male, and they show that they also have the same type of very good outcomes as the females, and the same type of complication with stricture and dysuria in a few rare cases. One of the last two phenomena that I want to discuss tonight is the overactive bladder, or detrusor hyperreflexia. It's something that is very well described in women, where there is a certain urgency and a transient short emission of urine, which is unpredictable and unrelated to anything. Obviously, in humans, because they communicate, it's a bit easier for these women and for the practitioners to identify these issues. In dogs, it's often presented as a dog that goes to the bathroom, has a normal position, a normal voiding time, but then will continue to emit some urine maybe 10, 15, 20 minutes after voiding. Just a few drops, nothing major, but very consistently almost all the time. There is no other leakage, there is no soaking of the bed, there is not all of these other patterns that are described in the two previous conditions that we discussed. It's really something that is associated with voiding and post-voiding emission of urine. Again, urodynamic studies would be your gold standard here to interpret the relationship between bladder contraction, bladder filling, and urethral tone. Still not much more available than when we discussed them 2 minutes ago for USMI. So I have never done a urodynamic study in these patients, but I've personally used oxybutynin as a treatment trial to try to relax the detrusor a little bit further, and had good improvement, although no complete resolution in these cases. Detrusor urethral dyssynergy is, or vesico-urethral dyssynergy, is a rare condition that has been described mostly in one case series of 22 large and giant breed dogs. And the clinical signs are fairly specific, with a dog that will posture and be unable to void properly, but then will walk away and start dribbling urine for a few minutes to a good 15-20 minutes. These dogs often initially have a normal neurological examination, and they have, when they present, often a bladder overdistension with a very, very large bladder. And the more chronic the cases, the more distended the bladder. They are very easy to catheterize, and they have normal, extremely frustrating, standard imaging studies. When you do contrast studies, though, like retrograde contrast studies using a urinary catheter, you can eventually identify spasm on the urethra if you have a good enough radiographic machine, or if you are using fluoroscopy, you might be able, doing dynamic studies, to identify spasm along the urethra that are not really coordinated. Once again, the urodynamic profile would be clearly the gold standard here. However, again, fully not available except at that one place in the UK or in Paris. Treatments have been variable, and there are a few options that have been reported in the literature or in professional group chats like VIN, or some specialist listers as well, with alpha agonists to try to relax the internal sphincter and allow for the urethra to open when the detrusor is contracting. That would go through the form of prazosin or tamsulosin. They've also combined this with the use of benzodiazepine to then relax the striated muscles of the urethra. And then other medications such as dantrolene and baclofen have been used to try to improve even more the relaxation of that urethra. If you suspect that there is bladder atony and that the detrusor is not able to contract properly, bethanical could be added to the mixture. But as you can see, it's a bit of hit and miss and trial error with medication to see which one improved the patient's condition. Urethral stenting has been described with very various results, and in my little experience, fairly poor results, leading to complete incontinence or dislodgement of the stent. But that's another topic that maybe Daniela wants to intervene on at the end of the talk. And the prognosis for this patient is guarded in the sense that the more obstructed they are, the more distended the bladder is, the more damages to the detrusor the more problem you will have to address that and allow them to void properly and empty their bladder. They might have UTIs, moreover, if the owners are catheterizing regularly to empty the bladder. And obviously, once they are on medication, it's a lifelong medication. And the final condition that I wanted to touch on today is detrusor atony. We already briefly touched on that when we did the differential list earlier. It's associated with often neurological damages at the level of the sacrum or the pelvic nerve. You have a decreased perineal reflex in this patient, and you have a very easily expressible bladder. You have a very distended bladder that will damage these intricated fibers of the detrusor. They are not intricated anymore. They are spaced up, and therefore their ability to contract and to void the entire content of the bladder is compromised. If you suspect that this is a complication, an immediate complication that may happen because you've done a surgery or you have a trauma patient, you can place a urinary catheter and maintain the bladder very, very small to help this muscle healing. So basically, like if you were doing sports, you would put yourself at rest. You put that muscle, that detrusor muscle, at rest with the urinary catheter doing the job and allowing the bladder to never really fully fill. Medications such as bethanical or more anecdotally cisapride have been described to help with the detrusor contraction. However, again, once the damage are there and there is remodeling and fibrosis of that muscle, you might not get a good response to medication, and that will be a very compromising disease in terms of quality of life for the patient and associated with very heavy discussions with the owners when the management starts to become complicated. So in conclusion, I think incontinence can impair the quality of life of the patients and the owners. That as a veterinarian, it's one of these cases where a thorough history and a thorough description of the urinary pattern is essential and will help you tremendously to already triage through that very broad differential that we have reached at the beginning of the presentation. And once you've done that, you will be able to prioritize your investigations. A lot of these conditions have a good prognosis and can be addressed either medically or surgically. It is important, if you've ruled out urolithiasis and urine culture, that if you suspect USMI, you would consider doing maybe a treatment trial if that's what the owners would like and it's not damageable for the patient. Then if you are looking into more of these rare but more severe conditions like dyssynergia or bladder atony, then it's important also to have very thorough conversations with the owners about complication, quality of life, and the limitations we may have to treat these patients. Thank you very much for your attention, and I hope I can answer some of your questions. I think some of these topics would be great to discuss with Daniela anyway, so I'm sure we're going to keep going and discuss all of that together.
Thank you, Benoît. Very nice presentation. I think you need to unmute the second computer, please, if you don't mind. So very nice presentation, very interesting, and you gave me loads of points to ask questions. I don't want to take advantage of you. So I would also like to give a room and space to our audience, because this is really a topic that is very actual in the general practice. So before I crack on with my questions, maybe we have two guests in the backstage. One is Elisabetta Mancinelli, who spoke, who did a webinar on anesthesia in rabbits. And then we have also Jane Ladlow here with us. So do you want to let them in? Hello.
Hello.
Hello. Hi.
Hi.
Hey.
Hello, hi. I'm fine, thank you.
So we are trying, for people on the other side of the camera, we are trying to get as many speakers as possible in this 21 live episode, just because we want to celebrate the large donation that we have had, and we want to celebrate that we have reached right now 13,000. And by the way, I would like to thanks, and hopefully still online with us, Carmack McCarthy Han, who is a final year vet student at the UCD in Dublin. So it must be one of your student, Benoit. And this, I'm very proud of that, because this demonstrates how our webinars are also very useful for veterinary students. And Cormac, thank you so much for your donation, and just spread the voice, spread the word with your other student colleagues, because these webinars can be followed, are recorded, and they can be followed if you guys register on the YouTube channel Vet on Here, and there are all the 21 webinars, the next one. And obviously we have the Elisabeta's webinar, we have Jane webinar on the BOA, so just spread the word to all your students' mates. So yes, Jane was again one of our at the beginning of this adventure, nearly now 2 months ago, and she made a beautiful presentation on the BOAs. And Elisabetta, as I mentioned, she did the presentation on the anesthesia in rabbits. So okay. So how are you, Jane? How are things?
They're good. So I'm really sorry, Benoît. I missed the beginning of your lecture because I was traveling back, but I caught the last bit of it, and it was super interesting. Super interesting.
Yes.
Thank you.
I have one question, because I've been watching Laura at Cambridge do some interesting work on the golden retrievers, and it's obvious that quite a few of the dogs with ectopics are not showing up with clinical signs when they're young. So for the affected breeds, would you advocate that we do screen these dogs now? So how much should we be searching for these ectopic ureters rather than just waiting until we see the incontinence?
I think it's always the debate of if there is no clinical manifestation, should we treat them or not? The thing with male, which I did not present in the discussion, is that they are often able to compensate, and so they are diagnosed a bit older. So in predisposed breeds, I guess if there is any sign of UTI, like even if it's not incontinence, obviously I would be cautious and investigate in detail. We had a dog here who presented for like intermittent hematuria and ended up having an ectopic ureter. So they don't, in male dogs particularly, they don't always have that typical incontinence. Obviously, if there is like recurrent UTI or hematuria, even though there is no incontinence, I would treat the ectopic if that's what we identify.
Yeah. Thanks, that's really interesting. And my other question is just a cheeky one. If you had to choose one imaging modality, which one would you choose? Okay.
Cystoscopy.
Yeah, me too. Just
like I've been trained to do ultrasound cystoscopy. I've been doing CTs here in Dublin because that was kind of what they were doing before, and so I was happy to try and see what we would gain. I will admit that for male dogs, I really like them because it kind of helps me feeling confident where I might find that opening when they are so tiny and in the middle of all of these prostatic canalicles.
Yeah.
But so far in female, I can't say that a CT has changed my ultimate decision to scope or to do anything to that dog.
Yeah, thank you. That's cool.
Yes, if I can comment also, Alison Berendt and Chick. So in particular, Alison, she always says that cystoscopy is the 100%, has the 100% sensitivity. So it's just a matter to understand whether they are intra or extramural, but most of them, 90% or 95% of them are intramural. So with the cystoscopy, so I do agree with the cystoscopy is the way to go. Yeah. Elisabetta, what about urinary incontinence in rabbits? Have you got it?
Occasionally, but it's not so common as I can see in dogs, to be honest. Yeah. The urethra is within the vagina, so sometimes when the vagina is very flaccid and fills up with urine, and then it overflows. But yeah, it's not as common, and unfortunately we don't have all the options for treatment. We don't have much information about the possible causes, I've seen it probably a couple of times, not particularly common, and usually the space solves the problem. So I've never actually seen it secondarily to a spay. And
so what
ectopic...
Oh, sorry. Yeah.
Sorry?
Yeah. Yeah, I was
ectopic
asking.
ureters, yeah. They've been reported, but they're not so common as I can see, as I've just heard in dogs.
Fantastic. Very interesting. Okay. Do you see the question, Benoît, for you?
Do you see the question? In human medicine, is women tropsion chloride is quite commonly prescribed in experience in dog. I have never heard of that drug.
Yeah.
So if anyone else has any input, I'm happy to leave the floor to anyone. I've never heard of the drug, so I would have to do some research before I actually can answer.
Thank you, Stein. Merci beaucoup. So I have a question. Let's go with an easy one. You have mentioned PMMA, so the paramesonephric membrane remnant. Okay. Yeah. So do you laser it as well?
Yes. Yeah, I do laser it all the time, and I was trying to find a video, but obviously I decided to find it today, and then it became just impossible to add it to the talk. I do like to show my residents when I do it how much improvement in the closure of the urethral meatus it brings, because I think the entire urethra, as I've repeated many times, is important. And it's really the combination of all of that will lead to continence, to an appropriate closure. And so that paramesonephric remnant will force open the urethral meatus. So when you laser it and cut it, it allows for the meatus to close better. So I always look for it, and I always laser it.
Yeah, I agree. And I think talking about the profillometry of the urethra, I think Laura used to do it, Jane. Am I correct? Or is she still doing it?
I think she's still doing it. So I think it's moved on a lot. So I think it used to be a little bit more crude, and I think now she's got a much nicer system. And I think it seems to be interesting, but I'm not sure what her results are as yet. But I think she was trying to work out if there was a difference between colpo and doing the sphincters in that way.
Yeah.
Oh, very nice. I didn't know Cambridge had the device. Sorry about that.
No, don't worry.
Was just thinking, because when you were mentioning, I remember I visited once Laura, and she was doing the profillometry, so it was very interesting to. And here we have
possibility of ditrisor atony in an 8-year-old male-neutered dog for 4 years, treating for recurrent UTI. The dog was presented for poly or polypsy, and based on his pulmonary causes of Cushing's disease, signs disappeared after treatment initiation, except for urine leakage and distended bladder. Neurologies. Okay. Well, it's hard to say for sure, just like right there without doing more. I think if you have a severe poly or polydipsia, I would try to make sure that this is not still ongoing. And even with Cushing's treatment, we know that it doesn't always necessarily go away. I don't think, and I might be wrong, we might have to call Laurent Garozzi back, but I don't think you would get ditrisor atony from PUPD, because the neurology, like the innervation of the urologic system, is normal. So the dog should be able to void. It's just going to void more often and sometimes inappropriately. So I would probably continue to investigate more inappropriate urination in that case, and an underlying PUPD or a behavioral issue that's developed because the dog is now used to void kind of a bit anywhere.
Oh, Cormac. Hi, Cormac.
Cormac. So I didn't speak about anuria, but for sure in any of the pathologies that we've discussed tonight, if there is a full obstruction, there will be a backflow of urine and a stasis of urine in the urine and eventually the pelvis, and that will lead to AKI. Now, AKI is a big umbrella term, and will there be clinical consequences that we can detect from this AKI? Probably not in early stages, but now for sure in dogs with chronic obstruction, very distended bladder, that might be a complication long term. It also might be a problem for dogs with chronic UTIs who might have ascending infection and develop pyelonephritis and eventually AKI from that.
I have another question.
Go ahead.
So have you got experience of USMI in cats?
No, I don't.
No, because I don't remember I've seen any.
I've not seen any for sure, and I don't recall reading anything about them, except maybe for boards, and I forgot it since.
I've seen one. Yeah, I saw one. Very young kitten, severe incontinence. And it was more like a congenital. So actually you do a very simple little cystoplasty and it fixes it. You feel great, right? So for a surgeon, it's lovely. But it's severe incontinence. So yeah, I like them, right? But you don't see them very often, I don't think.
Yeah.
So.
Oh, we have Yaisa and Steinbeck. Hello, welcome back. So
hello.
Have you got any question for Benoît?
Always, because it's a fascinating topic, right? And a really important topic because, you know, it might not sound as exciting and as other topics like, I don't know, heart attacks or cancer or so on, but actually incontinence leads to animals being euthanized. You know, it's an incredibly important topic for us to deal with. So well done on a great talk. Yeah, I had a question about sort of the laser procedure for ectopic ureters, because we're opening up a more proximal entry point, right, of the ureter that is still intramural, which means therefore that we leave the distal part of that ectopic ureter in place. And I never hear anyone talk about any complications that might arise from the fact that we still have that abnormal bit there, or it is a normal bit but in an abnormal position. So I don't know, what would you say about that?
So I think it doesn't cause any problem because it kind of resorbs and it's now then embedded in the natural folds of the urethra. And when you rescope these dogs a few weeks later, so like that Labrador Alpha from the presentation, I scoped her back 8 weeks post the first ablation, and you couldn't see at all the previous track that you had lasered. And so I think there is a complete resorption, and that is what I like to tease the surgeons here with, is that when you have a very distal ectopic ureter, I know they try to suture them closed, but I do highly doubt that it has the same effect and that there is a complete a resolution of the abnormal tract and the abnormal tissue when we compare both techniques.
We do like to you know, get one up on the surgeons, I guess. So here's one of them. We've got all the other chronic diseases that we can't fix on the other side of the balance, but here's one for us.
So you can have Boas any day. I would love to hand it over, right? So any day
we took anal furunculosis from you guys already, so you know.
Right. Definitely have that one too.
So we have another guest who is David. David Girardi was a guest one of the previous live episode, but we don't see David. Maybe your camera is off. Nope. We have some technical problems.
I've got a question for Benoît. If in the meantime, while you try to solve the problems backstage, so I want to ask you about the occluder for USMI, and you mentioned strictures as a complication, and so how often do you see that? And is the solution then to remove the occluder, or do you then, and do those guys then end up being continent because they've had a sort of a stricture? How does that work?
Yeah, I think I think for me, the main thing with the occluder is that they are all going to stricture to a certain degree. And that's why we don't inflate them right away. We actually inflate them a few weeks post-surgery to see how they do. If we go back to Alfie, the puppy, male puppy that had his occluder placed, we actually never inflated it because after the occluder was placed, there would be enough fibrosis and reaction around that urethra to tighten it to a degree that was fine for him. If they really stenose and have dysuria, there are a few case reports of occluders that have been removed, and they actually describe a very nice fibrous band that has developed between the occluder and the urethra. And I guess they try to break it down, which doesn't always work very well. You can try to balloon them as well, which probably would be my approach once you've removed the occluder from the outside, to then a few weeks later balloon that urethra. I have never had one that I had to consider more than that and like discuss stent or anything like that, but probably Daniela or Jane might have had more experience than me with them.
Yes, we sorry, Jane, go ahead. Yeah.
No, you go ahead first, Daniela. You're probably more than me.
So we have had a couple of where the occluder has caused stenosis around the urethra, and when we have removed the occluder, and then there was a really nice fibrotic membrane around the urethra, which you open and try to debride or to remove, and luckily the dogs were okay afterwards. But this is one of personally one of my concerns. Therefore, before placing an occluder, my personal opinion is I would go first maybe with a colpoid suspension, and if colpoid suspension fails, then I would consider the occluder. What do you think, Jane?
So Laura does my urinary in Cambridge, which I'm delighted about. And she had the same effect. We saw a really quite unpleasant stricture or fibrosis after a cuff. So we tend to do the colpo first because it seems to be difficult to cause major issues with a colpo. So, and it's more natural tissue. So I'm the same. We tend to do the colpo first and then resort to the cuff occluder if it doesn't work. Yeah. I also had one memorable case where the dog was actually continent. Sorry, no, it was incontinent during the day. That was it. And it was obstructed at night. And it was just a nightmare. And then when I handed the dog back to the owner, having had a total disaster and taken the cuff off, she turned around. It turns around that she was the nurse that looked after anuria and nocturia in humans and children in Cambridge. And she did say to me, well, it isn't that simple, you know. And I thought, oh, okay, fair enough. Okay, I take it on board. You know? So yeah, memorable dog that I managed to absolutely obstruct at one stage, and then it's like, thank you. So I've had a few disasters with them as well, I guess.
And what about collagen injections? Because is that how? What's your opinion? Your personal experience on that? And is that something that you ever consider offering, or do you offer first an occluder and then a collagen? Or I'm talking to Benoît now. For those cases that fail the medical treatment, what's the position of the collagen injections on your list of things to offer?
My problem with the collagen injection, and that also is maybe due to my small experience, is that I have a hard time to find a patient for which I can justify to spend that money and do something that is minimally but still a little bit invasive, and that might last just 6 months, and then we're back to square one. So I think the patient that I've seen have it were people that were very adamant that they didn't want to go to the occluder yet, and they wanted time to kind of probably make up their mind. But if the patient is young, 6 months, like, it's not going to cut it, and you will have to repeat, which I don't even know how many times you can repeat it, and then end up doing something else, so surgery or an occluder. I think for palliative, for an old dog that maybe has other problem or is incontinent for an other reason, and 6 months or a year is already, a good quality of life time for that dog, would be probably a great candidate for me, but I have a hard time to justify it in younger patients. I don't know if Jane or Daniela have different opinions.
We haven't done many, to be honest with you. It looks great. I think Laura was quite enjoying them. They look amazing, but and I think they worked quite well. But I don't think we did many at all.
It's very fun to do. Like, don't get me wrong, but it's just the effect is so unpredictable. Like it's hard to sell to an owner when you tell them that you can't say if the dog is going to be continent in 6 months to a year and a half.
Yeah, I think that's very fair.
What is very predictable is that if you go to justgiving.com/Vets4Ukraine, you will be able to donate for the good cause to help Ukraine out. And a little bird has told me in the back office room, the engine room of Daniela and Paolo's fantastic effort, that we are at quite a memorable point. So I believe that at this moment in time, we've got £12,999 in the kitty for the Vets4Ukraine appeal. So all going towards the British Red Cross, all going towards helping those in desperate need. So what we need, therefore, is for anyone watching this to be that one person that gets us to the magical £13,000, and we are getting close to beating the neurologist in a very friendly way, of course, but nevertheless, we like a bit of healthy competition. So please, anyone watching us out there just now, go to justgiving.com.
Let's see the
video. Was that Daniela?
So there is a video that we should watch all together to have this £1 to reach the 13,000. Paolo, because I know it's Sunday night and we
just need to reiterate the quote from Bob Geldof years ago, which was, "Give us the bloody money."
Yeah, okay, maybe. Okay, give us the bloody money. I was not sure whether to repeat this or not on the live to give the bloody money, but give us the bloody money. We need you to have them. Elisabetta, where are you? Oh, there is David now. Hello, David. We lost you for a moment. So you are mute. Hi, David. How are you?
Good. Very well. Thank you very much. Good evening to everybody. Congratulations for this nice talk.
Thank you.
How are you, Daniela?
Oh, we are all fine here. We are all very well. And we were waiting for you because you have good news to tell us from your front as well.
Yes, I have some very recent and exciting news. We have two of our Ukrainian friends starting working today for us in a clinic in northeast.
Can you mute the second computer you got by you? There is a echo?
No, I only have the phone right now.
Okay, because you are echoing anyway. Doesn't matter.
Sorry about that. Can you hear me okay now?
I can hear you, but yeah, go ahead. Yeah.
Okay, I may try to get organized with the computer if it's a problem. Anyways, Tatiana and Alessandro, our first two Ukrainian guests, friends, have started today to work as technicians, which in Italy is a translation for nurses. And they have their own contract, which is a perfectly normal Italian contract. And they're working in this 24/7 in Ferrara. So we are very happy to have started, a proper workmanship relationship with them. And so they are independent, they can provide for themselves, and they're quite happy. And this is the first two. Then tomorrow we have international meeting with the board that allows the recognition of the title as veterinary surgeons from the Ukrainian to the Italian. So tomorrow we have the first recognition. And that means that probably the other ones will follow through, which again will allow about 7 friends, colleagues from Ukraine to start working in Italy as vets from the beginning of next month. So we're quite happy about this news and the fact that, through a fairly slow process, but through the laws, the assistance of many people, we have managed to give, back dignity to these friends of us.
David, for those of you who haven't followed the live when you were our guest, you want to remind us that you are the CEO of which group?
Yes, I'm the Italian General Manager, CEO for Vet Partners Italy, and we belong to an international group which is quite present in England, in France, in Switzerland, in Spain, and in Germany. And we are pretty much involved with trying to help as much as we can with the current situation in Ukraine. So we are offering shelter and hospitality to these friends and colleagues. We call them brothers and sisters, to be honest. And we use what is available for everybody, which is the international regulations. So what we're doing is pretty much, you can repeat this in any country. England is pretty active. England is a bit more complicated for the recognition of the title. Pretty much depends on the countries. So we are starting in Italy, and hopefully we'll do the same in the UK, where we have a specific office and with a specific team of people helping out in order, first of all, to provide shelter and hospitality, and then, a job for our colleagues.
Fantastic job, David. Thank you. Thank you for letting us know about this. And because we are all here diplomats and specialists, so we have the president of the EBVS, which is the European Board of Veterinary Specialists, has shared our link. Paolo, do you want to show this to everyone, please? There we are. So here, thank you. I don't know how to pronounce DipACVIM-SAIM, who is congratulating us for all our amazing job. Not to, sorry if I say all our amazing job, but it's what we are doing, and we can be really proud. And I thank you, all of you, because you are just a part of the group, but they are an important part. Thank you so much. Elisabetta, do you want to ask any questions, or to, I don't know, maybe because the urinary incontinence is not very frequent in
Listen, I would say I would like just to add a few things regarding rabbits. Is sometimes we do see urinary incontinence, but as part of other problems. For example, you've got spinal problems, you've got fractures, you've got arthritis. As a secondary thing, then you potentially may have urinary incontinence, and then you've got the whole problems of related to echoniculi. So I think probably seen, but related to completely different situations as opposed to dogs and cats. So I don't think that it is, many things can be extrapolated, and sometimes, unfortunately, in rabbit medicine, we lag a bit behind compared to dogs, to dog and cat medicine in general. So, unfortunately, we are still learning.
I was also thinking that maybe because if the owners keep the rabbit like a cat, so the rabbit can go around in the house, or they would notice that they are incontinent. But if they live in a cage, maybe they don't even notice that.
It depends, because sometimes what they would notice maybe is other things. They may notice urinary scalding, not necessarily the incontinence, or they will notice changes in, urinary habits or toilet training, these sort of things, rather than necessarily the incontinence. Maybe you get to, the incontinence by asking questions, but they not necessarily, unless they leave a pool of urine, for example, when they're sitting down or they're standing in their own pee or urine, they don't necessarily recognize that there is a problem. Or sometimes we do see when they've got hypercalciuria, which is very common in rabbits because obviously of the different calcium metabolism in this species compared to dogs and cats. So I think the conditions are slightly different, I guess, from from other companion species, and may not necessarily relate. And ectopic ureters are not such a massive problem in, or at least it is not very frequently seen as it seems to be in dogs. So, but it was a very interesting presentation. I mean, lots of thoughts, to maybe think about when we do see rabbits. But yeah, I'm not so sure we can get to some of these things. For example, the cystoscopy can be done, but in females is easier. In male rabbits is a bit more difficult. And we tend to use more CT sometimes as opposed to cystoscopy. Cystoscopy may be useful for other reasons, but not necessarily for example, ectopic ureters. But, the situations and the size, unfortunately, of the animals sometimes limits, our diagnostic workup.
Yeah, talking about cystoscopy, is also true that in females is, I'm talking about females, dogs, and maybe big cats. It might maybe be straightforward, but when in males, it requires specific approach. And this is actually exactly the next question to you, Benoît, because there is the perineal approach that you at least this is how I do it. So with the perineal approach with progressive dilators, do you use that approach, or do you do the mini surgical approach, or how? So do you ask a surgeon to do it for you, or do you do yourself with the dilators? And you are on mute, Benoît. You're on mute.
Sorry. Yes, I do the perineal approach with the dilators, like you described, with like fluoroscopic guidance initially.
Yeah.
I guess the very first time I did it, I was very scared, so I asked the surgeon to be with me in the room, but she did nothing except watching me, and so since then she decided that she was not going to scrub in with me anymore. So I do them by myself, and they've been going fine so far.
Yeah. It's a little bit of a pain at the beginning when you are still in the learning curve. So yeah, it's not.
Yeah, and also like it's still a lot of incision for me. Like, I mean, what I do the most invasive thing I was doing before was a bone marrow biopsy. So quite a different thing to do. But they go well. My main limitation at the moment, or my main frustration at the moment, is once you place. So basically, for people who don't know what we are talking about, we make male a female for a few hours because we access the horizontal aspect of the urethra, which is coming just off the bladder, goes through the prostate, and just before it turns down along the perineum to go towards the penis, we enter that horizontal portion of the urethra to be able to use a rigid cystoscope, because there is no way to be accurate and precise and safe if we were to use the laser with a flexible scope. And to be able to do that, so we do a transcutaneous approach of the urethra, and we catheterize the bladder through that, and then we use dilators to create enough space for the scope to go in. And my problem is I've been using, like, again, I've done it 3 times, so it's not like it's my most common procedure either. But I've been using the peel-away sheath that is described in the publications that describe that technique, which is a 16 or an 18 French, and it's very tight on my scope. So I don't have a lot of room when I have the ureteral catheter and then my scope parallel to it for the laser to move and position myself very well. And that's why in that video, actually, the lasering was not exactly where I wanted it to be, because I don't have enough room. So I have to see if I could accommodate a bigger peel-away sheath maybe in the next male dog that I will do.
But you sorry for asking, you leave the urinary catheter in place when you go in with the scope? Okay. So
no, but once you've placed your ureteral catheter.
Yes. Okay. Yeah.
then you go back in, you have the urethral catheter and you have your scope parallel to it with your laser in, ready to go. And I found this very tight and sometimes a bit difficult to angle myself in a position where I'm comfortable for the laser.
I understand.
I don't know, do you use very big pill away sheaths in these male dogs?
But I haven't done millions of them. I've done probably 3 as well. So it's not that I have. So Laura probably has more experience. So, but I go up to like what is it? 18 French.
Okay.
So I just go. But because I'm a surgeon, I'm more rough in what I do, no, compared to a medic. You medics are like tick, 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 tick. Well, no blood, nothing. With surgery, I'm wrong.
I'm sure like, you know, if I break the urinary tract of that dog, I can't repair it. Versus if you break it, you know how to fix it.
Yeah, but come on, there are other colleagues that, for example, they are not very happy with the dilators, and they do a mini surgical approach. So then you can.
I will probably try a bigger one next time then.
Any other comments?
I've got another question for Benoît. Sorry, I'm squeezing your knowledge completely tonight, but I found it very, very interesting. So you talked about USMI and in male dogs and testosterone. So you talked about a monthly injection, but do you have any experience with oral testosterone? Does it work? And is it less good, or is it not worth trying, or what do you think?
So, if I'm being honest, I've used testosterone in 2 dogs and it did not work in any of these dogs. But I've only ever had access to the injectable form, so I have no experience with the oral one. So I would not be able to really answer your question. I think if the absorption is good, I don't see why it would not work, but I don't have any personal experience or knowledge about it. And I assume the side effects and the behavioral changes, which is usually what the owners are the most worried about, would be the same with the oral form.
Yeah. No, thank you.
Jane,
sorry.
Maybe, sorry, Daniela. Maybe another reflection. I'm just watching Benoît there giving answers to all our questions, and it just makes me think about what an excellent example you are of a very enthusiastic, self-made person who actually is a role model for many out there trying to make their way in veterinary medicine. I mean, a little bird told me that you did 2 internships, Benoît. Is that correct? I know we're changing topic, but I think these are also really interesting things to talk about.
You keep saying a little bird. It's not right, a little bird, no? The bird that you are talking about. It's pretty big bird.
Well.
So I did 3.
But is that true, Benoît?
I did 3. I did a clean path specialty. I did a clean path specialty internship to start with, which made me realize that I love hematology, but I still need to see my patients. And then I did 2 rotating internships before I could secure a residency position.
Yeah, and not all of those internships were paid. Is that correct?
I mean, depends what you discuss. Not
that any internship is really paid appropriately, but yeah, I mean, we don't have to go into details, but it just shows us that Benoît is a very driven person who had a passion for something and went out to get there, the goals that he wanted to achieve. I mean, I think you should be really proud of yourself, and I think a lot of people watching this will see you as quite rightly as a role model of how you don't let the fact that you were born in France, where perhaps at the time the opportunities were not plentiful, stand in the way of getting where you wanted to be. Because you went to Canada, now you're in Dublin, and you're clearly doing a fantastic job. So great respect for that, and a great example to all of us, really. You know, the passion shines through, and even the older folks, which I'm, becoming part of in the profession as well. Get inspired actually by younger colleagues coming through the ranks and showing the passion and really stimulates myself as well to keep doing my best, basically. So thank you for that, Benoît.
Well, no, thank you very much. I think all of us had to go through this kind of hardship more or less to achieve what we wanted. Like I don't think anyone gets a residency easily ever. I assume that probably for the one of us, like all of us who are not English speaking, maybe takes an extra few steps, because most of the residencies are in English speaking countries. But I don't think there is any easy path towards specialty. So any specialist is in the same position as me, I assume.
Yeah. Were there moments where you were, late at night, without much sleep, doubting that you were doing the right thing?
No, I think when I applied for, when I secured my residency position, I knew I was ready to apply one more time if I were to fail. So in North America, you apply through the matching program. So you apply to a bunch of positions at once, and then you get an answer, yes or no. Like basically, yes, you go there, or no, you go nowhere. And I knew that I was ready to maybe work or do whatever, but apply one more time to that round of applications for residencies, and apply in Europe in the meantime as well, and see if I had a chance there. So I didn't reach the point of despair where you question yourself and you wonder why you might have spent all of these years doing internships and nights and things and not getting what you want. I was lucky in that sense that I managed to get what I wanted out of it.
Yeah, luckily you didn't reach that point. And I've been at both sides of the table, and Jane probably sits regularly at that side of the table as well, where you've got an array of applicants with fantastic CVs that I did not have at that point in my career. And then one has to choose like one person for amongst 30 applicants with fantastic CVs as well for that one position. And it's really a good lesson for everyone trying to make their way in this profession in whatever way, that sometimes it's just being lucky and being at the right place at the right time to be chosen by people. And when you're not chosen, it's not meaning that you are not good enough or that you are inferior to whoever was chosen. It just sometimes comes down to the fact that there is only one place for multiple applicants. So I think it's very important for people to realize that. And if you've got that dream of going somewhere in this profession or other professions, don't let one or two or three decisions that didn't go your way stand in the way of still keeping that energy up and trying to achieve what you wanted to achieve. And Benoît, you therefore are a shining example of that. You've it sounds weird maybe to say that, but you are making it. Maybe in some ways you've made it, but that wasn't apparent necessarily in the middle of that journey. Perhaps not on paper, but you made it happen. So let it be an example to many of you out there as well. Keep dreaming the dream.
Thanks.
On that happy note, I'd just like to apologise to all the people I interviewed and didn't take. And to the ones I did take, I'd like to say you've all been brilliant. And I see so many people now that I've taught who are so much better than me. And I'm delighted, okay? So apologies to those of you I didn't take. Delighted with the ones I did take. And I'm actually going to sign off now, guys, because I've got a busy day tomorrow. But I'm so impressed, Daniela and Paola, with what you guys have done. I'm super impressed, okay? So total respect to Vets for Ukraine. Thank you.
Thank you, Jane. Bye, Vanessa. Bye. Elisabetta. Thank you for being with us. If you don't have any further questions, any further comments, go as well. Thank you so much for being with us. It was a super pleasure, and hopefully you will come back in one of our lives to have like a nice chat like we are having now. Thank you, Elisabetta.
Thank you very much. Have a good night. Bye.
Bye.
So I think, guys, we are at the end. No, I think I'm really. Oh, David, you are back because you disappeared at some point.
On and off, yes.
Yeah.
Thank you for what you're doing, Daniela and Paolo.
Not only, no. It's thank you to everyone, because the group is fantastic. All the specialists involved are fantastic, and the participation for other people like you, belonging to a different reality from ours. It has been you, Unisvet as well, Vin. So I think it's like a joint force here that is giving the outcome. Yes, Paolo is now putting this just to remind that, for example, Freddie has donated his entire income of his webinars or lectures for Unisvet. The same, he was not the only one. Also, Schwan Specky and Maurizio, Paolo helped me. It was Maurizio Longo also donated income. So thank you to all these people that are not now actively doing the Vets4Ukraine 2022, but they have donated their income. Therefore, dear friends on the other side, before we say goodbye to you until the next webinar with Luca Ferrazin with a cardiology topic, I would like to invite you to donate for our cause and support our work, because you see, all together we have reached this extraordinary result. So we just need one more pound to touch the 13,000. Keep donating and keep following us, keep spreading the word, and keep sharing the link. So I think, David, thank you very much for popping today, and we will see you. I'm sure we will see you again, and we will speak to you again. Thank you. Good night. Take care.
Thank you.
So,
Bye.
Yaisa and Stein, we will stay in touch anyway. So every now and then you pop in. Thank you so much for your support, and to Vin for the big donation. I think it would have not happened if it wasn't for you. So, and we're very grateful. And Benoît, beautiful talk, amazing. I enjoyed it a lot, and I'm sure all our the audience as well. Thank you so much, and keep in touch.
Yes.
Okay. Good. Bye. Thank you.
Thank you very much. Bye. Have a good night, everybody.
Bye, everybody. Good night, and see you next time. Bye. Bye.